It's a pleasure to be invited back again by Martin and also to participate with these other outstanding speakers, many of whom are good friends of mine. Okay. So I decided to pick two of the most challenging pathologies I treat in my practice. By the way, after looking at those pictures in the previous presentation, I am so glad I went into sports medicine. But my two most challenging pathologies are the adult-acquired flatfoot and heel pain. And I'd like to share with you a different perspective for treating both of those. This is a picture of the town where I practice in California. This is Seal Beach. Seal Beach is a beautiful little coastal community about 25 miles south of Los Angeles. A week ago, we had our largest storm surge in the last 50 years. A hurricane came off the coast of Mexico and sent 15 to 25 foot waves into Seal Beach. This is Seal Beach right here. The waves were so big they actually touched the pier. And it was a fantastic experience for people who like to surf. But this is what we're talking about today. This is a flatfoot. And I often give this talk to surgical conferences, to fellow surgeons. And almost before I have a chance to describe the patient, I'll have people already suggesting remedies for this, surgical remedies, whether it's a medial displacement calcaneal osteotomy, tendon transfer, arthrodesis, etc. And after I listen to the suggestions from the audience, I'll point out quickly, this particular patient came into my office with no foot pain whatsoever. He came in to have his orthotics replaced that I had made for him about 6 years ago for plantar heel pain, which resolved, and he continued to function well. He's a 72-year-old retired dentist who has run 52 marathons. So the question is, how could someone with a foot like this function that well and run 52 marathons? And what would you call that foot? Is that a pathologic foot? Is that the adult acquired flatfoot? We're going to attempt to answer that in just a few minutes. So the question posed to the audience is, why do we see patients with flat feet who function extremely well, and we see other people who are so-called dysfunctional with significant symptomatology? We used to use the word posterior tibial tendon dysfunction. I was down in Australia earlier this year, and they call it tib post, which is kind of interesting. But to blame it on the posterior tibial tendon is very short-sighted. And we use the term adult-acquired flatfoot, and it's really embodying this functional or this dysfunction where we lose dynamic and the static supportive structures of the arch, the hindfoot, and the ankle. Just to remind you, those dynamic structures which support our arch include the plantar aponeurosis, the posterior tibial tendon, and the plantar intrinsic muscles. The static structures, the spring ligament complex, the superficial deltoid ligament, the long and short plantar ligaments. And as I'm going to show you, it's probably these static structures that are really more important in the progression of this pathology. As I mentioned, this is really not a disorder solely due to rupture of the tibialis posterior. We've seen in numerous cadaver studies that if you take a normal cadaveric foot and you attempt to create a flat foot from that normal foot model, you have to cut much more than just the posterior tibial tendon. In this first paper by Deland at the Hospital for Special Surgery in New York, they had to cut all those structures before they saw a visible collapse of the foot or a deformation of the arch. Later, Meyerson's group, who have written much on this subject, they did cadaver studies to create a flat foot, and they too found that they had to cut multiple structures, not just the posterior tibial tendon. They had to cut the spring ligament, the long and short plantar ligament, and sometimes even the plantar fascia. This study done in Seattle, interesting study where they created that flat foot model by cutting the posterior tibial tendon and then those key supportive ligaments. They tried to reattach the posterior tibial tendon and apply physiologic load to raise the arch back up again. And when they did, the arch did not correct. So the conclusion of these researchers was once you lose ligamentous connection in the ankle and hindfoot, you cannot restore function simply by restoring the posterior tibial tendon. They also, interestingly, pointed out the importance of bracing the adult-acquired flat foot, and the critical part of the gait cycle is just prior to heel rise. If we look back at Jacqueline Perry's work, I borrowed this slide from a guy in the back of the room. She was the first to point out this biphasic contraction of the tibialis posterior. It contracts right at the moment of heel strike to decelerate pronation of the hind foot. It then goes relatively quiet at mid-stance, and then the more important contraction is just prior to heel rise. This has been validated in a more recent paper by George Murley at La Trobe, who's done a lot of great work on electromyography and foot orthotic therapy. And he just published this paper this year showing again this biphasic activity of the tibialis posterior, duplicating what Jacqueline Perry showed us. But interestingly, on the bottom right-hand side of this slide, he showed a biphasic contraction of the peroneus longus. And he proposed that there's a synergy of contraction of both the posterior tib and the peroneus longus that's quite intriguing, working in synergy to counteract or augment the stability of the foot in the frontal plane during heel rise. So it's right there on the left-hand slide where the failure of the posterior tibial tendon muscle unit has left the hind foot in a pronated position, and now the contraction of the heel cord becomes a pronator of the foot rather than a supinator. The triceps suri can be a powerful supinator of the hind foot if the hind foot is positioned properly, and therefore it relies on the posterior tib. Interesting to look at this insertion of the posterior tib. This is from Serafian's book, and it's an elegant dissection showing the multiple insertions of this tendon, not just at the navicular, but into the midfoot. And interestingly, if you look at the front here, this is the peroneus longus tendon coming across from lateral to medial, and indeed, the posterior tibial tendon anchors into the peroneus longus and helps stabilize it. And then as Murley showed us, this interesting co-contraction of the peroneus longus with the posterior tib, what we might conclude from that is how important it is to stabilize the mid-tarsal joint. This drawing from Netter way back shows this bipennate arrangement of the actual muscle of the tibialis posterior, and that the fibular origin is actually more important than the tibial origin. These researchers in Japan pointed this out and speculated that the posterior tibial tendon, or the muscle, is oriented better to control the foot in the transverse plane because of the arrangements of the muscle fibers. And indeed, when a patient does suffer a rupture of the posterior tibial tendon, we see this massive change of internal rotation of the tibia and abduction of the forefoot. That's one of the key clinical findings of these patients that differentiates the pathologic flat foot from the functioning flat foot. We look at this patient where the asymmetry, the symptomatic right foot, looks quite different than the left foot, not just in the abduction of the forefoot, but in the massive transverse plane rotation of the tibia and fibula together. Look at her lateral malleolus on her right foot and how anteriorly translated it is as the entire lower leg has internally rotated significantly on her right foot compared to the left foot. It's interesting when we look at these patients from behind, they look like they have an everted calcaneus. But we're starting to take these X-ray projections. This is called a standing rear foot view. It was described by Salzman in Foot and Ankle International, where we take an X-ray and we see that the calcaneus really isn't everted. We see that the talus and the tibia have been significantly medially displaced on the calcaneus. And when we step behind and look at the patient, the soft tissue outline gives you the false impression that the heel is everted. But it isn't really as everted as you think. It's the distortion of alignment due to the medial displacement of the talus. This transverse plane motion is what's so critical in our evaluation and our treatment of the adult-acquired flat foot. These kinematic studies that have been published in the last 10 years of patients with posterior tibial tendon dysfunction show a significant increased AB-AD adduction around a very high inclined axis of the subtalar joint. And when we watch these patients walk, particularly in swing phase, we see how much they carry the foot in an abducted deformity that must be controlled not just with foot orthotics, but more effectively with bracing. This ligamentous rupture, this loss of static control of the foot, is what's so critical and what we've learned in the last 10 years. And I just want to review with you what those key ligaments are. It starts with the spring ligament. And as we've seen from Deland's work and using MR imaging, that he found that there is a significant involvement of the spring ligament in even early stage of posterior tibial tendon dysfunction. And in his studies, he found it was just as prevalent on MR imaging as was pathology within the posterior tibial tendon. A more recent study published in the Podiatric Surgery Journal last year suggests that we should maybe redefine what we call this injury, because it is just as prevalent to see spring ligament involved as posterior tibial tendon. And maybe we should call this spring ligament dysfunction rather than posterior tibial tendon dysfunction. Why is it important? Well, when we classify the adult acquired flat foot, we really need to move beyond this almost archaic system described by Johnson and Strom, which is still used today, both in your country and in our country, where we just use these very confusing subjective analysis of what the foot looks like, whether it's flexible, whether it's rigid, whether they can do a single foot heel rise, whether they show, quote, too many toes. And the problem is that we're overlooking the more important anatomic structures that have actually been damaged, which need to be addressed either conservatively or surgically. So happily, in the last 10 years, a newer classification system has been proposed in the orthopedic surgery community, where these academic foot and ankle orthopods broke down the Johnson and Strom system and came up with subdivisions based upon the anatomic changes within the foot. And I'm not going to go into these in detail, but I just want you to appreciate the importance of breaking down these various categories, where stage 1 actually has 3 specific subcategories depending on whether the inflammatory changes are due to spondyloarthropathy or due to mechanical overload of the tendon. What was needed for a long time is what's available now, and that's subdivision of stage 2, the flexible, reducible adult acquired flat foot, where we now have 5 subdivisions based upon the degree of forefoot deformity, which we call forefoot supinatus, and whether that deformity is rigid or reducible, and whether there's been significant subluxation of the first ray or the medial ray. The rigid deformity, the hindfoot valgus that is rigid and non-reducible, is a much easier category to discern because it's rigid. And then finally we have the ankle valgus, which is really determined by radiographic evaluation. Okay, so we take this classification system and we can go even a little bit further. This is a wonderful paper published in the Podiatric, the Journal of Foot and Ankle Surgery, by a group of orthopods and radiologists at Johns Hopkins University. And here they used elegant MR imaging combined with clinical exam of the patient with adult acquired flat foot and came up with subclassifications based on which ligaments were ruptured. And these images are just beautiful to look at and appreciate that now with adequate positioning of the patient and with MR, we can see the spring ligament and the degree of rupture, and we can see the superficial deltoid ligament and the long and short plantar ligaments. And based upon those ligamentous ruptures, these surgeons proposed various interventions, whether it's ankle foot orthotic therapy or actual surgical procedures based upon the degree of deformity or the degree of anatomic disruption. Do we need to do that, though, in the initial evaluation? No, it's not cost effective, and actually it's rarely helpful in our decision making of how we initially treat the adult acquired flat foot, because the treatment is almost always conservative. So I'm going to give you just a few little clinical pearls of how you might detect a foot that has ruptured key ligaments and become dysfunctional. So we often start with a patient in the clinic with the weight-bearing analysis. This is what I do. I interview the patient, but I do not touch their foot until I bring them out into a hallway of the clinic, and I do a standing assessment, and then I watch them walk. And in this case, we gain immediately the appreciation that this is an asymmetrical deformity. Her more symptomatic foot is her left foot. There has been structural change in her left foot compared to her right foot, so this is automatically a stage 2 deformity. Yes, you can say there's too many toes on her left foot, but there's also the medial displacement of her rear foot, of the medial malleolus, on the calcaneus, which is quite apparent from the posterior view. As I said, you can learn more by looking at the patient from the front, because these patients will often show this marked internal rotation of the fibular malleolus, or the internal rotation of the entire tibiofibular unit, as well as the asymmetrical abduction of the forefoot on the rear foot. It's a little more subtle here on the patient's left foot, which is the symptomatic foot. Look at the bulging of the medial malleolus. Look at the fibular malleolus on her left foot compared to her right foot, and you'll appreciate that it's anteriorly translated because the entire foot is internally rotated on the tibia. To determine flexibility, it's best done in a weight-bearing position, and you will try to correct the hind foot. Whether you have the patient supinate their foot, whether you externally rotate the tibia, you want to see if you can neutralize the rear foot position to vertical and reduce it. And this is certainly a reducible deformity, so it's not a stage 3, it's a stage 2. But the real question in my mind is, have ligaments ruptured in this foot? We already know that there's been a change of appearance of the foot, but are there loss of ligaments, particularly the spring ligament? Now, the first test that we can do in the static assessment, in the weight-bearing assessment, is we call it the Hubscher maneuver, and I think you call it the Jack test, right? So the question is, who was first, Hubscher or Jack? Does anybody know? Hubscher was an American, obviously. For our purposes, we will call this the Jack test to avoid any political discrepancy. And in this test, we lift the hallux and we activate the windlass mechanism, and the tibia externally rotates, right? Okay, try this on patients with adult acquired flat foot. Now, this is an older patient, and she has, as they all do, flat feet on both sides, but one side's flatter than the other. And as you lift the hallux, it raises the arch, and if you look at her tibia, it externally rotates. But when we try it on the other foot, well, I'm going to back up, and try this yourself, you can't lift their hallux. You can't activate the windlass. And for years, when I gave this lecture, I always said, well, it's because they've attenuated their plantar fascia. But it's interesting, if you look at studies, now, a lot of these MR studies now on adult acquired flat foot, they have not ruptured their plantar fascia. It's the one ligament that's still intact. Yet, they do not have an active windlass or Hubscher maneuver. Okay, this is from Deland's work. The plantar fascia did not show significant involvement in these patients with stage 2 PTD. Yet, I try to lift her right hallux, and I can't get it off the ground, and I don't raise her arch. Why is that? Well, it's because she's had ligamentous disruption. If they don't have a spring ligament intact, the Hubscher maneuver will not work. The Hubscher maneuver requires a stable medial column of the foot to transfer movement through the medial column to the tibia. Okay? So this may be a good test for spring ligament disruption. Here's a good test. This is called the single foot heel rise. This is a great test to do in your initial evaluation. And in the healthy subject, just like you see here, they can not only lift the heel at least 6 inches off the ground, but the hind foot should be observed to invert. And when they rupture their posterior tibial tendon, as these experts say in Foot and Ankle International, they can't do a heel rise because they're weak, is what is postulated. Okay? Now that raises a question. Why would they rupture their posterior tib and be so weak they can't do a heel rise? Is the posterior tib an active, powerful plantar flexor of the ankle? Because that would be the assumption here. And it is true, when a patient ruptures their posterior tib, they can't do a heel rise. But it's not because they've lost plantar flexion weakness, or they've lost plantar flexion strength. If you look at these studies, of the tibialis posterior, it is the strongest supinator of the hind foot, yet it's the weakest plantar flexor, by far the weakest. Just look at the anatomy. The posterior tib tendon lies right next to the ankle joint axis. It has no lever arm whatsoever. Certainly the longest lever arm is the tendo Achilles. Yet you rupture the posterior tib and you can't do a heel rise. You can't do that. And the reason is, it's not just a matter of plantar flexing your ankle when you do a heel rise. It's the fact that you're elevating the entire foot off the floor due to a stable arch, a stable mid-tarsal joint, where the plantar flectory moment is delivered not just at the ankle, but across the metatarsophalangeal joints, where the entire foot plantar flexes on the toes. And in order to do that, you have to have a stable beam, a stable rigid beam of the arch of the foot. So if you watch patients, and these gait studies now have shown, these kinematic studies have shown that patients, one of the key kinematic findings is they have too much sagittal plane motion through their midfoot. They have flexibility, so to speak, through their midfoot, or we might say they have an unlocked mid-tarsal joint. This has been shown by studies by Houck and Neville. They've done some wonderful work and published it in multiple journals, but they're showing excessive plantar flexion of the hind foot on the forefoot through the mid-tarsal joint. You can see this when you do your single foot heel rise. Watch the patient attempt a heel rise when they have a deficient posterior tibial tendon and probable rupture of the spring ligament. And the entire rear foot plantar flexes on the forefoot across the mid-tarsal joint. Watch the tibia move anteriorly or translate anteriorly as the forefoot stays on the ground. That's an unlocked midfoot, probably a ruptured spring ligament. So you see that characteristic breakdown of the midfoot when they attempt a single foot heel rise, which in many cases limits the ability of the foot to gain leverage and rise off the ground. Okay? Now let's look at our dentist who has a flat foot and has run 52 marathons. I asked him to do a heel rise. No problem whatsoever. The difference between him and the other patients that I showed you just before is that he has a stable mid-tarsal joint. He has not ruptured any ligaments in his midfoot, and his flat foot functions as stable as a high-arched foot because his ligaments are intact. Okay, a little preview for tomorrow. I'm going to give you a lecture of my insight into the stability of the human foot and how the arch can be raised or lowered in the human foot. And a lot of it has to do to look at at other primate feet. And one of the interesting things about primate feet, that's on the left-hand picture, is a chimpanzee in terminal stance. And that foot breaks down just like the adult acquired flat foot does at mid-stance, the chimpanzee foot. And of course on the right is the healthy arch. And so if you want to learn more about this and how you can reverse that, make sure you come tomorrow. Don't just come today. You've got to show up tomorrow, okay? And we're going to talk about this midfoot breakdown and how we can affect that with foot orthotic therapy, okay? Just a little preview. Okay, back to the exam of the patient. Let's bring the patient into the treatment room and do muscle testing. And the best way to test the activity of the posterior tibial tendon and the integrity of that tendon is the following. You draw an imaginary circle on the medial aspect of the head of the first metatarsal. You place your thumb on the bottom half of that circle and you push the foot to end range eversion, leaving the ankle plantar flexed. This takes away the influence of the tibialis anterior and allows isolation of the posterior tibial tendon. And the patient is asked at that point to push against your thumb. Push against your thumb and you compare to the contralateral foot. And you and the patient will feel the difference in strength right away if they've had a partial rupture. You don't need an MRI to confirm that. Do not do the test this way because it's activating, as you see there, the anterior tibial tendon, which will add a false degree of inversion strength that's not contributed by the posterior tib. This is an interesting test where in static stance you supinate the patient's foot. And as Hinterman showed us, regardless of the foot, if you invert the heel or externally rotate the tibia, the arch will raise and the first metatarsal will remain on the ground. But if they've ruptured their posterior tibial tendon, according to Hinterman, the first metatarsal rises off the ground. Very interesting. He calls that the first metatarsal rise. There it is. I've supinated her heel, and the first metatarsal rises off the ground. What this really is showing you is the presence of a forefoot supinatus deformity, which is very important surgically and even important conservatively when we do foot orthotic casting or AFO bracing. Recognize the fact that there's supinatus there. It's different than a fixed forefoot varus because it's reducible. And you must reduce it when you cast them for foot orthotics, or you will fail with that device or with their ankle foot orthosis. You must reduce it. This is an acquired deformity due to gradual breakdown of the medial column of the foot due to ligamentous attenuation. You can see supinatus often in the supine position in the exam chair. And here's how you correct for it when you're casting either for an AFO brace or a foot orthotic. You must do your normal suspension casting, but you must push down on the first ray and take the foot back to how it was before that tendon and ligament ruptured. And look at the difference in the shape of those 2 feet. That's the same patient. It's interesting, I'm going to show you this in my lecture tomorrow, to look at the embryonic development of the human foot. And if we look at this embryo on the bottom left, that's a human foot at about 8 weeks, and it has a tremendous amount of forefoot supinatus in it. Tremendous supinatus that gradually reduces during the embryonic development of the foot, and if it doesn't reduce, as we see in the final product in the middle slide, we end up with what we would call a forefoot varus, right? And as we see in the adult-acquired flat foot, it looks like an embryonic foot because the calcaneus lies lateral to the talus. And we're going to explore that further tomorrow. It's very fascinating. It's exactly what the primate foot looks like. The talus and the calcaneus lie next to each other instead of on top of each other. That's what the embryo of the human foot looks like. It's what the primate foot looks like. It's what the adult-acquired flat foot looks like. And we correct it by twisting the lamina pedis, or the plate of the foot, and that is the so-called twisted plate theory of foot stability, which we'll go through tomorrow. Okay, I'm going to quickly talk to you about correction. And this is a final test called supination lag. It's very interesting and easy to do in the exam chair. We have the patient sit with their feet hanging over the edge of the table, and we say, bring the soles of your feet together. You're really telling the patient, supinate your feet for me. And if they've ruptured their posterior tibial tendon, as this patient's right foot has ruptured, it lags behind. There's a patient with a left foot ruptured PT tendon, lagging behind the right foot. And in most cases, when they've ruptured the PT tendon, they can't cross the midline. So you drop a plumb line down from the tibial crest, and that's your point of reference, and they can't cross the midline. Here's a ruptured posterior tib on the right foot, a supination lag. You know this test, silver skull test, to detect a rupture of the or a contracture of the gastrocnemius. Probably important more surgically. And then for the surgeons in the group, this is an interesting test to do, is to look at the influence of the heel cord on these patients as it pulls the foot into eversion due to the already valgus alignment of the insertion of the tendo Achilles. Because his hind foot is everted, as we dorsiflex the ankle, the heel cord pulls the foot further into eversion. This becomes the rationale for the so-called medial displacement calcaneal osteotomy, which realigns the heel cord, or the Achilles, to the subtalar joint axis so that it becomes a supinator, not a pronator. Okay, that's a very powerful and popular surgical procedure for stage 2 adult acquired flat foot, and we use that exam on the operating table. This is a patient, before we do the medial displacement calcaneal osteotomy, we dorsiflex the ankle and the foot pulls into abduction. In the left, in this corrected foot now, we've put a K-wire through the calcaneus as we've medially displaced it, and on the left-hand picture she's at neutral, and then the right-hand picture she's dorsiflexed, and there's no change of alignment, meaning we've reestablished the alignment of the heel cord. Just kind of an interesting test. Okay, so basically when we treat the adult-acquired flat foot, we have three goals: eliminate pain, restore mobility, and most importantly, prevent progression of deformity. And in most cases, if there's been ligamentous disruption, the best way to do that is to reconnect the foot to the leg with plastic. You've got to control that massively, internally and externally rotating tibia-fibular unit. And I'm going to spend my workshops today and tomorrow describing in much more detail how we use functional bracing to treat stage 2 and stage 3 adult-acquired flat foot. So I'm not going to go into too much detail, except to show you that in some cases, good foot orthotic therapy can be very effective if they haven't had significant ligamentous disruption. This is a patient in stage 2 deformity. Interestingly, she just moved back to England here, and I referred her to somebody that Martin had recommended. And she's being controlled with very good foot orthotic therapy. What did I do? Well, I used the techniques recommended by two of my good friends, both graduates of the same school I went to, the California School of Podiatric Medicine. Kevin Kirby and Richard Blake have given us great ways to enhance supination control or supination moment arm to their hind foot in these collapsing flat feet, either with the medial heel skive technique or the inverted cast correction technique of Rich Blake. Okay? So I'm going to show you a couple videos real quick, and then we're going to move on to my phase 2 so we don't run out of time, okay? So this is a patient. She's not your typical adult-acquired flat foot because she's had a spinal cord injury from a careless surgeon doing a simple lumbar laminectomy, got a little sloppy with his scalpel, and severed a key part of her nervous innervation to her foot. So she has a drop foot and a very severe adult-acquired flat foot collapsing, but it's flexible. And so this just shows you the effectiveness of functional bracing on a patient like that. I took this video when she came in that morning. She'd walk 2 miles for exercise, as she does every day with her brace on. And she's relatively pain-free. She still looks pathologic, but her deformity isn't progressing, and she prefers this over a total ankle fusion, which would really be her only option. This is a really severe, this is a stage 2 or stage 3 deformity. Let me go back here. This guy's in his late 70s. This left foot is in severe valgus, as you'll, or his right foot. And I really didn't think I could even brace this guy with a traditional brace, but lo and behold, I did. And he carries on a very active lifestyle despite a deformity that would otherwise be extremely debilitating. So these can be among your most gratifying experiences when you treat patients conservatively to restore mobility to a patient who would otherwise be severely impaired. And I'm going to be sharing a lot more of those experiences with you in the workshop, which I invite you all to come to. Okay? Now we're going to change gears here and talk about my second most favorite topic, and it's plantar heel pain. Now, do people have heel pain in the UK? Do you ever treat patients for heel pain? We see it a lot in California, and I'll be the first to admit to you, I don't really have all the answers, okay? And I'm going to be totally unabashed and share my failures with you and show you a new technique we're using for those patients we fail with our normal conservative treatment. So plantar heel pain, you know, it's interesting. They're just now publishing studies on how prevalent it is, and in the United States, they now say that 10% of the population will develop plantar heel pain in their lifetime, which is pretty significant, okay? But what's interesting, if we look at what causes heel pain and the continued debate about not only what causes it, but the biomechanics of it. And this, I made this slide a long time ago, but we've blamed it on bursitis, periostitis, nerve entrapment, of course plantar fasciitis, etc. And if we look at the controversies with it, this is a picture from a foot and ankle orthopod in California named Glenn Pfeffer. And in his book, he's showing different locations of pain in the foot. And he said when a patient has plantar fasciitis, their pain is the brown circle, number 1, in the middle of the foot. That's plantar fasciitis. And if they have pain where I pointed with my thumb on that first slide, that's number 2 up there. That's an entrapment of the first branch of the lateral plantar nerve. Okay, very interesting. And this is an authority on foot and ankle pathology. I'm interested, though, in patients that have this. I think that there is a large number of patients with heel pain that have been victim of plantar fascia overload, okay? And we used to call this plantar fasciitis, but we've now learned from histopathologic studies, starting at the Philadelphia School with Harvey Lamont's work, that these specimens taken out of the heels of patients with chronic heel pain show no inflammation at all. They show internal degeneration of the plantar fascia, and the term should really be fasciopathy or fasciosis, okay? Now, what causes this overload of the plantar fascia remains very intriguing and debatable. And I'm going to spend a fair amount of time tomorrow with my twisted plate theory to show you why I know and how to treat overload of the plantar fascia with foot orthotic therapy. But going back to the literature, these are studies published in the last 10 years. We've got pretty good evidence that patients with patients that have increased weight gain, females, are at greater risk for heel pain, but there's been no correlation with foot type and heel pain, whether it's a high arch foot or low arch foot, or more importantly, pronation or supination. And this particular researchers say it's partly because we have difficulty measuring arch mechanics in vivo. This quote is still true today from Chrisman and Snook. They wrote this about heel pain in 1972. They said it's reasonably certain that a condition which has so many different theories of etiology and treatment does not have valid proof of any one cause. And that's why, in the United States at least, when a patient presents to a podiatrist in any city in the country and leaves that office, they will have a different treatment of every other podiatrist in the same city, I would almost bet, right? And it's probably the same here. And what's interesting is to look, there's studies on this now. How do we treat heel pain? This was a study published in Foot and Ankle International of a survey of academic foot and ankle surgeons on how they like to treat heel pain. And in this scenario, they asked, what would you do if a patient presented to you who'd had 4 months of plantar heel pain? What is your most preferred treatment? Number 1, a home plantar fascia stretch program. That was their favorite prescribed treatment. And lagging behind by 50% is supervised physical therapy. Foot orthotics, only 4% of the surgeons recommended intervening with foot orthotics. After 10 months, if the patient is still not getting better, 55% of these surgeons recommended surgery. 55% over every other treatment, including extracorporeal shock wave therapy. When it came to surgery, interestingly, the surgery wasn't a plantar fascia release. It was a gastrocnemius recession. Very interesting. Okay? That's a safer surgery, by the way, than doing a plantar fasciotomy by far. Then came a group of in the podiatric profession in the United States, the foot and ankle surgeons. And the American College of Foot and Ankle Surgeons published their position statement on how to treat heel pain. And as I put this slide together the other day, lo and behold, one of the authors is not only a friend of mine, but he's going to be here lecturing later today, Jack Schuberth. He's one of the authors up here. And he and his buddies got together and came up with this proposed protocol for treating plantar heel pain, and it's different than what the orthopedic surgeons recommended. Okay? They recommended, for example, padding and strapping, stretching, over-the-counter arch supports, and heel cups. Heel cups. Okay, that's very sophisticated biomechanics there. I wish Jack Schuberth was here to hear the wrath of my lecture on this. And after 6 weeks, the patient then might be considered for custom orthotics, but they have to wait 6 weeks and use a heel cup and stretch and be taped. And then they might get referred for physical therapy. Well, the physical therapy community saw those guidelines and they took great exception to it. And they said, following the ACFAS recommendations, there is likely to be a greater utilization of corticosteroid injections, oral medication, and radiographs in the first 6 weeks, whereas a greater utilization of manual therapy and exercise procedures may result from following the APTA guidelines, which is the Physical Therapy Association. They took great exception that the podiatrist would wait 6 weeks to refer for physical therapy. And they undertook a randomized crossover trial where they compared how the podiatrists are going to treat heel pain to how the physical therapists will. I found this paper and I contacted the lead author because I wanted to know if it had been published. This is the protocol. And she said they're halfway through the paper. It hasn't been published. It'll be very interesting to see because what these physical therapists want to prove, of course, is that if you refer early, you'll get a better outcome than if you delay the physical therapy part of the protocol. Okay, I have a feeling they're going to be right with that. So if we compare overall the difference between the two groups, the orthopedic surgeons favor stretching, physical therapy, and night splints. They don't favor at all structural support of the foot. They're very actually less likely to recommend corticosteroid injections than our podiatrists. But at 10 months, they're quite aggressive with recommending surgery. Okay? Podiatry, on the other hand, tend to go with corticosteroid injections fairly quickly. They will not refer for physical therapy until at least 6 weeks, and they don't even recommend custom foot orthotics till at least 6 weeks, which is, and to me, a little embarrassing. Okay, we can ask Dr. Schuberth about this later when he shows up. Okay. Now, doing plantar fasciotomies, just very briefly, have a lot of problems. As we know, these are all papers published in the literature with the prolonged recovery, arch destabilization, and even if you use endoscopic plantar fasciotomy, which is EFPR, lots of problems there, including portal tenderness, these so-called lateral heel pain, arch destabilization, and a lot of them get these pseudoaneurysm or laceration of the lateral plantar artery. So not a great option. PRP injections are an option that are gaining popularity, but if you look at the literature, the randomized trials show that it works about the same as a corticosteroid injection, but it's still popular. And then, of course, shockwave has gained more and more popularity, and there are more convincing papers now being published, a few level 1 studies showing that shockwave is at least as effective, if not more effective, than corticosteroid injection. But I like to share with you a treatment that I was trained to do about 5 years ago in the United States, and I've published a paper on it, and I just thought you might find it interesting. Even if you don't do this procedure, have access, I think you'll enjoy just seeing what the anatomy is and understanding just a different approach, and that's called radiofrequency nerve ablation for chronic heel pain. Now, radiofrequency treatment has been used for over 30 years for treating chronic back pain. It's a semi-invasive procedure to literally kill a nerve or neurolyse a key nerve that's creating pain, whether it's in the spine or other areas of the body. And it uses radiofrequency current that creates heat, and it actually irreversibly kills a nerve. But you have to be really careful how you do it. Okay? So these are systematic reviews done in the spine, and a lot of you may work with pain management doctors who use radiofrequency for chronic back pain. And some of them have been experimenting with extremity nerves, and you might even contact them to see if they'd be interested in doing this procedure I'm about to show you, because anybody who does it in the back could easily do it in the foot, because in the back it's a lot more scary. You're dealing with these mixed nerves that exit the spine, and if you do the wrong thing, you're going to end up severing a motor nerve and creating a drop foot or other problems. So you have to do it under fluoroscopic guidance, and as I'm going to show you, the machine helps you find the sensory component and avoid the motor component of the nerve. Okay? Now, not to be confused with another technology that became popular in the United States called Topaz. That's radiofrequency current used to actually cook the plantar fascia. You make multiple punctures into the plantar fascia and you heat it typically trying to create an angiogenesis or a repair cycle in the plantar fascia after chronic degeneration. That's not what I'm doing. That's not the procedure I'm doing. By the way, Topaz has really fallen out of favor in the United States because basically it just doesn't work. Okay? But this procedure does work. Now, it was first described in the podiatric literature as far back as 1989. And these were retrospective papers that were just reports of one or two practitioners of how they were using a machine similar to what's used for spinal nerves, but they were using it on the foot because they watched these pain management guys do it, and they were intrigued with it. So a company saw this and said, why don't we make a machine just for the extremities or just for podiatry, okay? And they call it Podiatherm. Okay, it's just for podiatrists, and this company told me we had to make this machine so simple to operate that even a podiatrist could use it. Okay, so basically, I'm going to take you through the procedure, but what I'm doing is I'm finding the inferior calcaneal nerve, and I'm going to ablate it with radiofrequency current. Now, you're going to first of all say, what is the inferior calcaneal nerve? And I'm going to show you. And this part I think you'll find interesting whether you do this procedure or not. So here's the anatomy and the so-called inferior calcaneal nerve. Now, the inferior calcaneal nerve is actually the first branch of the lateral plantar nerve. And I'm going to show you a lot more detail on that. The first person, well, actually the second person to describe this was, let's see if we have a pointer here. This is from Don Baxter. Now, you've heard of Baxter's nerve. Don Baxter, to his credit, did some cadaver dissections and said, you know, this nerve that comes off the lateral plantar nerve, we used to call it the nerve to the abductor digiti quini, is the nerve that looks like it goes right up into that area of the plantar fascia where most people have heel pain. And it seems to be the nerve that probably innervates that part of the fascia and the periosteum of the calcaneus. And to his credit, Baxter said the first guy to describe that nerve was not him, it was Pearl Zucke, who's a podiatrist from Chicago. Pearl Zucke described that nerve in 1981, yet nobody calls it Pearl Zucke's nerve. They call it Baxter's nerve. And Baxter himself gave credit to Pearl Zucke. And Baxter showed that in Gray's anatomy, this nerve, let's see how we do this. This nerve, I'll just use my pointer here. Gray's anatomy showed the nerve going very distal in the foot, yet when Baxter did his dissections, that nerve goes right against the medial calcaneal tubercle. And it innervates that part of the foot where most of your patients have heel pain. It innervates the medial calcaneal tubercle and the proximal plantar fascia. It innervates the periosteum and the fascia in that part of the foot. Okay? So here's a more appropriate drawing showing that first branch of the lateral plantar nerve. What did I do with that? Right here. Now that nerve is a mixed nerve. It's a sensory nerve that goes to the calcaneus, and it's a motor nerve that goes to the abductor digiti quini. Okay? And it's interesting to look and realize that a lot of your patients who have heel pain, wish I could get this to work, Martin. Oh well. There's a lot going on in there. If we look at that MRI, some patients have a spur. A lot of patients have thickening of the fascia. A lot of them have bone marrow edema, and that poor nerve is sandwiched right in there. Okay? Now, I believe the fasciopathy starts this process, but sooner or later it involves the nerve, because the nerve is pinched in that small little corridor right here, sandwiched under the plantar fascia and below the roof of the calcaneus. Okay, and if we look at these sonogram images, as soon as that fascia begins thickening, there's no more room for that poor nerve anymore. Okay? Now, here is the inferior calcaneal nerve. It's a pretty big nerve. It comes off of the lateral plantar nerve, and if you follow it, it goes right down and goes right under the plantar fascia. Okay? This is where the misunderstanding is. The medial calcaneal nerve is a superficial nerve that only innervates the skin of the heel. It's a cutaneous nerve. And I'll show you some studies that verify this. It's a very superficial nerve that innervates the fat pad and the skin. And I hear fellow professionals of mine who use alcohol injections for chronic heel pain, and they say, I'm going to inject alcohol around the medial calcaneal nerve. All that's going to do is ablate a nerve that provides the cutaneous sensation of the heel, not the deep fascia, not the periosteum, not the plantar fascia. This is a dissection showing the medial calcaneal nerve will innervate the fat pad and the bursa under there. And if you have a patient who has pure bursitis of the heel, maybe ablating the medial calcaneal nerve would help them, but that's rare. Okay? Here's the anatomic study showing that the inferior calcaneal nerve always originates from the lateral plantar nerve, and its relationship to the deep fascia and the abductor hallucis muscle and the anterior tubercle of the calcaneus may explain the entrapment syndrome of the inferior calcaneal nerve. Another anatomic study showing that the medial calcaneal nerve is a cutaneous nerve only. Okay? So, what I want to do is I want to go after that nerve. Okay, and I'm going to show you how we do it. Okay? I want to stick an electrode in and find that nerve, and it's easy to find because by palpation you find the proximal origin of the plantar fascia right against the heel, and you go about 2 or 3 millimeters above it, and the nerve is there every time. Okay, so I'm going to stick an electrode right at that point where the inferior calcaneal nerve goes under the calcaneus and goes above the plantar fascia. Okay, so here's how we do the procedure. I'll do this quick and then I'll be done. Okay, so I've marked where the upper limit of the plantar fascia is and right where it originates on the medial tubercle of the calcaneus, and I'm going to give her an injection about 4 or 5 millimeters superior to that. And I'm going to put a little wheel of lidocaine there to superficially numb her skin only. I don't want to numb the whole nerve. I need that nerve to be alive because I want to find it, and I'll show you why in just a second. So once I've numbed it, I'm going to put, this is basically an 18 gauge cannula. It's a very large needle with a hollow core in it. But it's amazing, once you've numbed the superficial skin, you can shove that cannula all the way across the top surface of the fascia, and they don't feel it. It's very interesting. They don't feel it until you hit the nerve, and then they feel it. Okay? Now, I'm going to stick my electrode through that hollow core cannula, and I'm going to start moving it across the top surface of the calcaneus, and I want to find the nerve. Now, to find the nerve, the machine sets an electrical current through the electrode to stimulate the nerve. And as you move across, you tell the patient, tell me if you feel any tingling in your toes, which often they do. They start to feel tingling in their 5th digit, but sometimes they feel more than tingle. They feel you actually hit the nerve, either the sensory or the motor component, but they don't scream, they just go, ow. Okay, so I move it around, and once I find that, now I'm going to show you a video of me doing this, but I got to turn on my, because you're going to hear her say, ow. Okay, I think it's very impressive, but she doesn't leave the room. She stays on the chair. Okay, so here we go. You couldn't hear. She just said, ow. Okay? So, now, I'm going to show you. Okay, this is another patient. I'm moving it around. And we now turn the machine to motor. And we want to see if we're in the motor component of the nerve, not just the sensory. And if you get a motor reaction, you got to move the electrode away because you don't want to cauterize the motor part of that nerve. And that's what's great about this technique, is it allows you to find the sensory only and not hit the motor, and therefore not wipe out the nerve to the abductor digiti quini. That's actually a good thing to avoid, because if you do hit that nerve, and other surgeons have done this doing a decompression, their baby toe folds under their 4th toe, and they are unhappy. It's a real nuisance for the rest of their life unless you surgically realign the toe. Okay? So, this is a patient, and I'll show you, I've got it in the motor component on purpose. And I'm going to show you, you're going to watch her baby toe abduct as the machine stimulates it. See the baby toe? So this is good because I know I'm right there, but I just want to move it back about 1 millimeter, stimulate the sensory, and I'm away from the motor nerve, okay? So I inject lidocaine through the cannula. I'm injecting lidocaine through to numb it. Now I put the electrode back in, and we turn on the heat. We heat it at 90 degrees centigrade for 90 seconds, and it ablates the nerve. Okay? And we do it in 3 locations, and they're done. We put a Band-Aid on, and they walk out. Okay? So this is the first paper published on that, and then this is our paper. We did a prospective randomized double-blinded study. This is a level 1 study with placebo to determine the efficacy of this procedure, and we followed the patients for 6 months, and we found a significant drop in pain in those patients who got the real treatment and no drop in pain if they had the sham treatment. When we crossed them over, as you see on the right-hand side, the crossover group immediately improved in pain once they got the real treatment. Okay? So very impressive statistics. And then what was interesting is after we did that, and Foot and Ankle International, a group of orthopods just last year published their prospective study of percutaneous radiofrequency ablation for chronic heel pain, and the pre-treatment level was 9.2 on a visual analog scale, and they show up to 2-year follow-up, a drop to 1.4. So it's very impressive. A safe treatment. It is operator dependent, but any pain management doctor who's doing this in the spine could do this in the foot. If you worked with them and showed the anatomy, which you know well, and show them where that inferior calcaneal nerve is, they can find that nerve and ablate it quite safely. They know how to avoid the motor part and only get the sensory part, and it's a very superior alternative to plantar fasciotomy. Thank you very much.